Thank you, Lauren. Thank you. I really appreciate it. Thank you for the intro. And hello to everyone who has come in and joined the session. I cannot see you, I cannot hear you, but I appreciate you. Thank you for giving us your time. So without further ado, we're going to go right into it. I want to thank our sponsors, Friendship Dental Laboratories and Dentbright Dental Labs. They are the ones who have sponsored this presentation and this session. So let's go right ahead and have fun with it. So let's talk about dentures in the age of digital dentistry. Okay, we have been doing dentures for a very, very long time. And when digital dentistry came along, let's see how that has changed this field. Now, the objectives that we're going to cover, we're going to talk about the production of preliminary and master models. We're going to talk about the analog ways of doing that, and also about how digital scanners and digital workflow has affected that. And then we're going to talk about record taking, the good old bite, vertical analyses, aesthetics, phonetics, all that stuff. And then we're going to see if those old principles, which are Pound's principles, developed by Earl Pound in the 50s, if they still apply. And then how to save time and appointments using something called a reference denture. We're going to talk a little about that. And then we're going to talk about try-ins, virtual setups and virtual try-ins, and how we do those and what benefits they provide. All right, we know, just like anything else we do in dentistry, dentures are supposed to provide, or should I say restore, health, function, and aesthetics. So our complete denture, in order to do those things, it needs to have proper support, proper retention, function, and aesthetics. This is the all too familiar workflow to make a complete denture. We all know that. We take a preliminary impression. Based on that, a model will be produced, and then on that model, the technician is going to make us a custom tray. We take that custom tray, we take a border molded final impression. That border molded final impression is poured, a master model is produced, and then on that master model, base plate wax trim are made. Using those, we do jaw records or intermaxillary records, and then based on those, teeth are set up, artificial teeth are set up. We try those in, and then if everything is good, that is processed and we deliver the denture. Or if it's an implant supported, fixed detachable, there's going to be a possible conversion. So it all starts with an impression. But what is the purpose of an impression? Well, the purpose of the impression is for us to capture what we need to capture and trace so that our denture can indeed provide proper support, proper retention, and have proper function and aesthetics. So let's take a look at that. The support, where does the support come from? This is a master model. So, well, it comes from the primary stress-bearing areas. The primary stress-bearing areas would be the palate, the zygomatic shelf, and the crest of the ridge when it comes to the maxillary arch. And the mandibular arch, that would be the buccal shelf, retromolar pads, and the crest of the ridge. These will provide us with the support that our denture needs. So our impression needs to capture that. If those are not captured properly and accurately, well, our denture is not going to have the proper support. What about retention? Remember in dental school, everybody's so freaked out about adhesion and cohesion. Oh yeah, adhesion and cohesion are the core principles of denture retention. Well, they're not. They play a role in the retention of the denture, but they are not the primary source of retention. Primary source of retention is actually the atmospheric pressure, or what we call the all too familiar border seal. If we have proper border seal, we have proper retention for our denture. The border seal is the contact of the denture border with the underlying or adjacent tissues to prevent the passage of air. So literally we create an airtight, almost airtight seal 360 degrees around the denture. And that's what's going to provide us with the proper retention. Okay, just like that, whether it's an upper or a lower. At the borders, we have compressible mucosa. We need to capture that compressible mucosa and the anatomic elements around them, and then the denture will press on that compressible mucosa, and thus it will create proper border seal, and we have good retention. All right, and that's why we always call that type of impression selective pressure. All right, so it's not only that, it's not only pressing on the compressible mucosa to create the border seal, but there are other anatomical elements that operate in those areas near the borders of our dentures. And our denture actually interacts with those elements. And if the denture does not respect those elements and their area of interaction, then they can compromise the border seal or they can create sore spots. Now, what are those anatomical elements? Well, you know those. Let's review them. First of all, you see the muscles. You got the muscles of mastication, muscles of facial expression, muscles of the floor of the mouth, and muscles of oropharynx. Remember those categories? Let's take a look at them. Let's take a look at muscles of mastication. Well, the two that really matter in this topic would be the masseteric muscle and the temporalis muscle, and both of them, they operate on the lower jaw. Okay, and there they are. That's where they live. That is the area where they affect our denture. And actually, during function, both these muscles are elevator muscles, so they close the mouth. So during closure of the mouth, when the masseter bulges out, it actually leaves a depression there, which we call the masseteric notch, right? If our denture does not respect that, well, then guess what? When the masseter bulges out, it can knock the denture off. Or if your denture is overextended there, if the masseter cannot knock the denture off, it can create a sore spot. What about the muscles of facial expression? The orbicularis oris, mentalis, buccinator, and modialis. They are all around in the labial, mesiobuccal, and distobuccal flanges of both the maxillary and mandibular denture. How many times have you seen a patient where they come and say, hey doc, when I smile, my denture falls off? Or if I want to whistle, my denture falls off, or it starts moving. That is because in those cases, the denture does not interact well with these muscles. During function, puckering of the lips, drinking something through a straw, whistling, or smiling, these muscles operate. They operate very close to the denture. So we need to capture them in operation. All right, what about the muscles of the floor of the mouth? Semihyoid, genioglossus, styloglossus, and hyoglossus. Okay, movements of the tongue. When the tongue moves and when the patient swallows, the floor of the mouth comes up and it can knock the denture off again, or compromise the border seal, or create a sore spot, right? How many times the denture has a patient says, you know, the denture is really good as long as I'm biting down, as long as I'm not doing anything, but as soon as I start talking, it starts moving. That's why. And then the muscles of the oropharynx. It's really the muscle on each side. It's the superior constrictor, but there's two of them because they come in pairs, obviously. So it's the muscles of oropharynx. It's the superior constrictor, and that's where they live. That's their area, in the retromylohyoid area or space. It is between the retromolar pad and the tongue. And when the patient swallows, that's exactly when that muscle bulges out. And then sometimes the patient comes and says, you know, I had this denture made, and it's good, but whenever I swallow, it hurts. That's because the denture is overextended there, okay? And when that muscle is in function, it hits the denture. That muscle is usually not strong enough to knock the denture off, but it definitely creates a sore spot. And the mucosa there is actually very, very sensitive. So when you take the denture off, you can see usually a very prominent sore spot right there. What about some other anatomic elements? Well, the freni. You got a labial frenum. You got buccal frenum. Sometimes you have more than one buccal frenum on each side. You got the labial frenum on the mandibular arch. You got a lingual frenum there. And you also have buccal frenums. Okay. So if the denture is not respecting those can become sore. Or if the denture is underextended, they can compromise the border seal. And here we are with the coronoid process. Okay, remember, the mandible translates when we open more than a certain amount. Actually, the condyles, first, they have purely rotational movements, right? But usually if you open more than, say, 11, 12 millimeters, what happens is the condyles will start translating and they come downwards and upwards. The coronoid process comes downward and forward, I'm sorry. They come downward and forward, and the coronoid process comes with the condyle. It comes forward and downward. And if the denture's in the way, it's going to knock the denture off. Patient comes and says, oh, the denture is fantastic, but when I yawn or if I open my mouth too much, it falls down. That's why the coronoid process is knocking it off. Okay, this is where the coronoid process lives when the patient opens. And you see it on the master model. So during the function, there it is, opening the mouth or moving the jaw from side to side. And the all too familiar hamular notches. Remember the hamular notch? Okay, so distal to that majorly carious wisdom tooth that you can see on this radiograph, you have the tuberosity. Okay. Most of the dentures that I see that come to me, when I look at them, I see that they stop at the tuberosity. But the tuberosity is not compressible mucosa. Tuberosity will not give you a good border seal. So the denture has to extend more posteriorly and go and extend into the hamular notch. Because the hamular notch, which is between the pterygoid process and the tuberosity, there you have compressible mucosa, and there you're going to have proper border seal if the denture compresses that mucosa. So the denture has to extend there. In order for the denture to extend there, you need to capture it in your impression. There it is, you can see it. And how do you identify it in the mouth? You're gonna need a T-burnisher. It's easy. Get a T-burnisher, go posterior to the tuberosity, keep going posterior until you fall into the notch. And then very easily just mark it with an indelible pencil, and then it gets transferred to the master model. What about the outline? The hamular notch is not the only element that determines the most posterior border of your denture. In the middle, it's the vibrating line or the ah line, right? I always say in prosthodontics, we say it as we see it. It's the ah line. Why? Because when the patient says ah, the mobile part of the soft palate and the immobile part of the soft palate are separated with an imaginary line, because the mobile part will drop down when the patient says ah, and you can see that line. You will then, with an indelible pencil again, you will mark it, and it will be transferred onto your master model. That is the most posterior border of your denture in the palatal portion. If your denture is extended beyond that, as soon as the patient starts talking, the denture will fall down. If the patient is using a ton of adhesive and the denture doesn't fall down, it will create a nasty sore spot there, because that part of the palate keeps moving when the patient's talking, and it keeps hitting the denture. It's very uncomfortable. So we need to recognize that and capture it and transfer it onto our model, whether it's a digital model or an analog model. Okay. And the famous post-dam, the butterfly-shaped compressible mucosa on each side of the midline, which is anterior to the vibrating line. That mucosa is compressible. It's scraped on the master model, and so the denture will actually compress that, and it will create proper border seal. Many dentures have come to me over the years, and the patient has been complaining about retention, and I look at it and they don't have post-dam, or they don't have a proper post-dam. That's why post-dam is very, very important for retention, but not just for retention. Also, it doesn't just maintain the border seal, but also it prevents food from getting underneath the denture. That's a common complaint. A lot of times patients go, when I eat, everything's good, but when I eat, food gets in. And a lot of times it gets in from the back. It's because there's no proper post-dam there. It also diminishes or even eliminates gagging a lot of times, because it can actually provide a sunken distal border. So it provides a smoother transition, a more seamless transition from denture to the mucosa. It's less noticeable by the tongue, and it can actually reduce gag reflex for people who have a strong gag reflex. And it can also compensate for the volumetric shrinkage of acrylic resin. This, when it comes to digital dentures, this particular advantage of the post-dam is not that significant, because a digital denture is usually either milled or 3D printed. So volumetric shrinkage that we get from processing the acrylic is not that significant anymore. But that does not diminish all the other advantages that the post-dam has. Now, what about this guy, the retromolar pad, a very, very important landmark. Now, a lot of times when we talk about landmarks, we need to bear in mind that if it changes over time, it's not a good landmark. Okay, crest of the ridge changes over time. Why? Because ridges resorb. So as the ridges resorb, it's like sand dunes in the desert. They move. Okay, they change location. So those are not good landmarks. What does not resorb over time are spots in the mouth and on the bone that have muscle insertions. Well, the retromolar pad has 3 of them. 3 muscles come together in the retromolar pad: the temporalis, the buccinator, and the superior constrictor. So it has 3 muscle insertions. So guess what? The retromolar pad is not going anywhere. It doesn't actually change position. Okay, it remains pretty much the same location throughout the person's life, I should say. So that's why retromolar pad is a very important landmark for us, and we're going to dive a little deeper into what we use it for. But we have about an hour of a presentation here, so a lot of things that we're going to be talking about, we can't really dive deeper into it. But I understand that we have actually a fantastic hands-on upcoming course in December. That's an all-day course, and that's where we're going to dive a lot deeper into a lot of the techniques and how we use the landmarks, and we're going to elaborate more about a lot of things that we touch on today. So everything that we talked about, all these anatomical elements, all these things that we need to capture, all these things tell you why we border mold, because we cannot capture and trace these without border molding. Border molding is what traces all these anatomical elements in function so that our denture can interact properly with them, and so that our denture is not overextended or underextended, which in both cases, it can compromise our border seal, okay? And that's why we border mold. So, do conventional principles still apply when it comes to denture impressions? Well, we have two types of impressions, right? We have the preliminary impression, we have the border molded final impression. When it comes to preliminary impression is always overextended. We want it to be actually overextended. We want to have more on our study model so that based on that we can have a custom tray. Okay, so when it comes to the preliminary impression, sure, you can do that analog with maybe a stock tray, or you can do that digitally with a scanner, because when you put the scanner in, most of the times when you try to capture the fold, you are overextending the fold. Actually, you're displacing the fold, you're displacing the muscle. So you are not capturing the fold in function, all right? It's overextended. But that's okay for preliminary, that's perfectly fine. So yeah, absolutely, you can do a digital impression for the preliminary. But what about the border molded final impression? Yes, the conventional principles absolutely apply, because with a scanner, you cannot border mold. Now, once you border mold, then absolutely you can scan that and you can digitize it. And we do it all the time. We do it every couple of days, pretty much. I think George will attest to that. We do a lot of digital, which almost 100% of the dentures that we do with Friendship, they're all digital, they're all digitized. So it works fantastically, but they always get border molded. They're always based off of a border molded final impression. Now, just like we talked about the preliminary, that's always overextended, and that's okay based on that a custom tray is made, the custom tray is border molded, we have a final impression, and that's how our final impression and the master model that is produced is not over or underextended, it is just right to give us the proper support and retention. All right. Now, what about immediates? What about immediates? Immediate dentures. When I say immediates, I mean immediate dentures. When a patient already has teeth, comes to us and we want to go ahead and do impressions. Well, here's the unique property of immediate dentures. If you go ahead and do a digital preliminary impression, and then use that even as a final impression, and go ahead and make a denture, make an immediate denture. You digitally eliminate the teeth, and then based on your records, the teeth are set up, digital dentures are made. Your impression is most probably overextended, okay? Or it's safe to say that it's definitely not just right, okay? Providing you with proper border seal. However, when the teeth come out, when the surgery is done, after you suture it up or the surgeon sutures it up, that act is actually altering the vestibule, the depth of the vestibule. So that act is actually altering the fold. So even if you have captured the fold in function via border molding after the surgery, it's not in the same place. It's not in the same place. Okay, So that is why with immediates, you will have to reduce the borders and reline the denture. Okay. Now, if you only extract the teeth, and these are not surgical extractions at all, then yes. But if you are doing surgical extractions, you are altering the fold. Because you're altering the fold, then definitely a reline is necessary. And the reline is actually a border molded impression. So you are doing your border molded impression actually at the time of delivery. So in the case of an immediate denture, if it's a surgical extraction, that's okay. You can go ahead and use your digital impression. I can totally do that, use a digital impression, make my denture based off of that, because I know I'm relining that denture later. And that can provide you with a lot of advantages, one of which being a case like this, 7, 8, 9, 10, blowing in the wind. They are very loose. So if I go ahead, get a custom trim, do a beautiful border molding, and take the final impression, as I am removing that, because my border molded impression has been done so meticulously, the amount of negative pressure that tray is going to cause while it's coming out, that most probably there's going to be 4 teeth in it. 7 through 10 is going to come out inside my impression. But what about a digital impression? What is your impression material? Light. That's not going to do anything to those teeth. So that's a good advantage that a digital impression can have in these cases. Okay, we go ahead. We have our impressions. We have a beautiful master model. And now we want to set up teeth. Well, where do the teeth go? There you go. Where to set the teeth? Well, here's the thing. In order to know where to set the teeth, we need to first know what the teeth do. Based on what they do, we can determine where they go. Okay. But what about immediates? Patient already has teeth. Okay, fantastic. But you still have to check. You still have to check the position of those teeth. And that brings us to jaw records based on Pound's principles. Remember the beautiful wax rims? Remember the vertical analyses, the interpupillary line, the midline analyses, the incisal inclination, the ala tragus line, all of that. Those are all Pound's principles, and that brings us to our jaw records, the vertical analyses. Yeah, there's the appearance, there's a space requirements, they all play a part in how we set the vertical. But all in all, we know that the vertical is held by the posterior teeth, not the anterior teeth, the posterior teeth. So if your patient doesn't have teeth, especially posterior teeth, that means you have lost that vertical. We may never know what the patient's actual vertical was. But we have guidelines. Thank God for guidelines, okay? And the guidelines, we all know it. The vertical dimensional occlusion is usually 3 millimeters on average, 1 to 3 millimeters less than the vertical dimension at rest. Okay. So that's one of the principles in Pound's definitions. The teeth also provide lip support, right? You have one of the pictures with the denture in and the other one with the denture out. And I certainly don't have to tell you which is which. You know, right? And also, that lip support will make the vermilion bordered lip more prominent, okay, which is aesthetically more pleasing, and it gives the patient a more youthful look. What about the incisal edge position? Well, one of the principles we go to is the aesthetic principle that usually addressed on average, people show about 2 to 4 millimeters of teeth, of anterior teeth. Now, that depends on the patient's lip line. Some people have a high smile line, some people have a low smile line. Some people show more teeth, some people show less teeth, but on average, it's about 2 to 4 millimeters. But it's not just that. You know, if you have an edentulous patient, you have a waxer, you put it in, and you're like, all right, so here we go, 2 to 4 millimeters. Okay, on average, that's one of the principles. But what if the patient already has teeth? Beautiful. It's easy. Just put the teeth where they are, right? Like Carl here, who came to me, he already has teeth. I was like, all right, that's already checked off. I know where to put the teeth. Give me a smile, Carl. And this is what I saw. All right. Which tooth would you like to choose as the reference for your incisal edge position? Because guess what? Carl's got one for every taste. Okay. So yeah, we need to go to our inomaxillary records and we need to go to our jaw records to determine which tooth is in the proper position, or if any of these are in the proper position. Okay. And one of the most important things would be phonetics. Okay, we have fricative sounds, we have sibilant sounds. Again, I'm not going to go too much into it because the time would not allow it, but you know there's a wet-dry line and the patient says 55, which is a fricative, the F is the fricative sound. So when the patient says 55, 8 and 9 should hit at or near the wet-dry line. Also, the sibilant sound, there's something called the closest speaking space. So that when the patient says S or Mississippi, then that space should be about a little less than a millimeter. That's the space between the lower anteriors and the palatal portion of the upper anteriors. Okay, those are the guidelines that can determine where the upper and lower anterior teeth are supposed to be. All right. What about the retromolar pad? A very important landmark. Remember that one? So we know that the occlusal plane, the height of the occlusal plane in dentate people would be about half to 2/3 the height of the retromolar pad. And we basically duplicate that in fabricating dentures. So that is a common misconception that I have heard some colleagues actually say that, oh yeah, those principles are for dentures. Well, we use them to fabricate dentures, but those principles actually came from dentate people. We borrowed them from natural dentition and we applied them to make complete dentures. Okay, so we apply the same principles when we do full mouth rehabilitations, not necessarily just not necessarily only with dentures, with full mouth rehabilitations too. Why? Because that's how teeth are in our mouths, ideally, optimally, I should say. Okay. And also the buccolingual position. We have something called the Pound's triangle. All right. It's an imaginary triangle between the mesial of the canine and the medial and lateral borders of the retromolar pad. When you have that triangle, we know that the lingual cusps of all the posterior, lower posteriors will be inside that triangle, and the lingual wall of all the lower posteriors will touch the medial line, the medial side of that triangle, like that. That's how we set up teeth. Okay, so that's an important guideline for the buccolingual position of the posterior teeth, which is again dictated by the retromolar pad. What about the occlusion? The maxillomandibular relation between the upper and the lower. Oh, it's easy. That's how your teeth fit together, right? You and I, we close our mouth, put the teeth together. Our brain knows exactly where to position the lower jaw. The teeth dictate that. Well, yeah, that's called the MIP, the maximal intercuspal position. A long time ago, quite a long time ago, decades ago, we used to call that CO, centric occlusion, but now we know that that is not the correct term. That has changed long ago, right? It is called MIP, maximal intercuspal position. Okay, that's the best way your teeth fit together. Well, we're talking about complete dentures. And in complete dentures, patient has no teeth, no teeth, no MIP. Guess what? Studies have shown that if your teeth are apart for about somewhere between, if I'm not mistaken, 5 to 20 minutes. The maximum, I think, is 20 minutes, but somewhere between 5 to 20 minutes. If your teeth are apart, the muscle memory is wiped. So your muscles of mastication will actually forget where your lower jaw goes so that your teeth will come together properly in MIP. The muscle memory is wiped. People who wear night guards know this very well. If the night guard is worn at night, it keeps the teeth apart, right? So however many hours of sleep you get, I'm hoping it's more than 20 minutes. So if you wear your night guard for more than 20 minutes and then you wake up in the morning, you take the night guard out, you realize that your teeth are actually not fitting together properly. That is because during that time, your muscle memory has been wiped and your brain has forgotten where MIP was. So there you go. Now, give it 5 minutes, it'll come back to you. Your brain will retrain your muscles of mastication. Everything is good. But if you extract the teeth, there's no MIP. There's no muscle memory anymore. Okay, so we do need a new maxillomandibular relation that we can record, and we can mount our case based on that, with that, and we can make our dentures based on that. Okay, so what properties should this maxillomandibular relation have? Well, first of all, it needs to be independent of tooth contact. It should not be MIP because there is no tooth. So it should be independent of tooth contact. It should also be clinically discernible, which means we need to be able to record it. And thirdly, maybe most importantly, it needs to be clinically reproducible. Every single time when we go to record it, it should go to the same relation every time, and that makes it reproducible and verifiable. Does such maxillomandibular relation exist? Well, thankfully, yes, it does exist, and it is called the all too familiar centric relation, or CR. Okay, according to the latest definition in the glossary of prosthodontics, the centric relation is a maxillomandibular relationship which is independent of tooth contact because it is a condylar relationship. It is not a dental relationship. It is restricted to pure rotary movement. It is physiologic and unstrained, and it is clinically repeatable and reproducible. Okay, so when we go to record the CR, there are many ways to record it. Again, we cannot go into details, but because of time. But when we go to record it, you got to remember, because it's independent of tooth contact, it should be recorded at an open vertical. When you are recording CR, teeth should not touch. That's why I always record the CR using hard base plate wax. The teeth should be apart because the moment the teeth touch, patient will go into MIP instead of CR. And if the patient doesn't have teeth and you have wax rims, the moment wax rims touch, one of the two things will happen. Either your base will move, so now you have recorded the movement of the base, not the CR, or it will guide and you will go into a different relationship, which is not CR. Okay. So that is why you always record the CR at an open vertical. We know it's repeatable, so you need to verify it. You record it, then you verify it, and if it's different, you have to do it a third time. And then once you do it the third time, the fourth time will be, you guessed it, verifying it. Okay, so you got to make sure that it's repeatable. It's limited to hinge movement, no translation. Okay, and again, it's verifiable. There are many different techniques to capture CR, the cartridge tracing. There are devices such as the Lucia jig, which was developed by Victor Lucia, and other techniques to record the CR. But most importantly, you got to remember, look at this case. I actually saw this patient last week. Came to me, one of our immediate cases that we are currently doing with Friendship. So this is how the patient bites in MIP. And I thought it's a great case to show for this presentation so that you see how different the records can be between MIP and CR. Look at this. Look at the incisal embrasure between 24 and 25. Okay. Now, you see where that is? In this patient, actually, I'm telling you, please take my word for it because you can't see the patient's face, but the facial midline is actually coincident. It actually coincides with the labial frenum, which you can see in this picture. Okay, so you see how the incisal embrasure between 24 and 25 does not coincide with the frenum. This is how the patient bites in MIP. This is how the patient is in CR. Did you see that shift? This is how the patient is in CR. And actually in CR, the incisal embrasure between 24 and 25 does coincide with the patient's facial midline, which you cannot see. But again, it coincides with the labial frenum in this case. All right. So I'm going to do this again. I'm going to go back to MIP and look at the shift to the patient's right. That's MIP. That's CR. That's MIP. That's CR. If I make my immediate denture in this position, once the teeth come out, the patient's not going to be in this position anymore. Physiologically, the muscle memory will be wiped and the patient will go into CR. The patient will close in CR. So now the patient will close in this position, which means if I do that, my bite is going to be way off. It's going to be in a totally different zip code. Okay. And that's a common problem that a lot of times we see that some colleagues encounter. Oh, you know, I made the denture, I took the bites, but then I put the dentures and the bite was completely off. Well, maybe it's because the CR was not recorded properly. Because once the teeth come out, that's all you have. It's the CR. Okay. I have Friendship always make actually my base plates in the immediate cases with rod wire clasps. You can actually see it on tooth number 5 right over there. The bases are excellently retentive with rod wire clasps, and as you can see, I always record the CR using hard base plate wax. I cool the wax inside the mouth, and then I verify it and make sure that it goes to the same place every single time. I know that this picture might be a little deceptive, but please take my word for it. The teeth are apart. The teeth are not touching. If I show another view, which I don't have this presentation, you'll see that the CR is actually recorded at an open vertical, because as soon as the teeth touch, guess what? The patient will go like this. We'll go into MIP. We'll go with the shift. So, with all the things that we said, do conventional principles still apply when it comes to jaw records? The answer is yes, they do. So, where does digital dentistry come in? Well, actually, once we do our preliminary digital impression, the lab can make you a custom tray combined with wax rings if the patient is edentulous, obviously, or if you have, they don't have sufficient posterior support. then you're going to have a custom tray. You're going to have wax rings in an edentulous patient. Together with that appliance, you can actually get a border molded final impression. And now you have a very retentive base with wax rims, which will have the same retention as your future denture will have. And then with that, you can have your intermaxillary records. You can record the CR, verify it, and then either you scan it or you can send it to the lab scans it, and then you can have a virtual setup and a virtual try-in. All right, this was a case that actually came to me. It was an immediate case. We did the vertical analyses, the aesthetic analyses, phonetics, aesthetics, the whole 9 yards, okay, and we determined based on Pound's principles where the teeth will need to go. Digital model, the models were digitized, and then we had Kevin expertly set up teeth for me. And a lot of times, actually, when Kevin is setting up teeth, I am right there with him on the screen. That is one of the great advantages of the digital workflow. As your technician is setting up the teeth, you are right there and you're actually doing it together. You can put in, you can have your inputs. You can check the incisal inclination. You can check the tooth show. You can check and make sure that everything's exactly the way you want. So that's what Kevin did and does on a daily basis. I really cannot ask for a better team than all the superstars of Friendship Dental Laboratory that make my life easy, really, every single day. And I thank them for that. So based on that, we did our virtual try-in. You can see what the patient has, what the virtual setup looks like, and on the computer, we set up the teeth together, and the patient left with this immediate denture. All right, this is another case that we did together. Again, we did the vertical, functional, phonetical, and aesthetics analyses, and based on that, we determined where the teeth need to be, where they need to go. We did the virtual setup together. Again, Kevin did an awesome job. You see the occlusal plane, half to 2/3 the height of the retromolar pad, where the upper and lower anteriors are set up. You see the Pound's triangle, everything that we talked about. You see how seamlessly they come together in the digital workflow, and you can actually check it right on the monitor. And not just that, with the patient's picture, you can actually do a virtual try-in, put it inside the patient's mouth virtually, check everything, and then the patient went from this to the upper immediate, and actually the lower we converted, and then eventually the patient received fixed detachable on both upper and lower. All right. Now, what if the patient comes to you and has something like this? This was a denture or whatever you want to call it that the patient had that came to me like this. I looked at it and I was like, oh, okay, well, clearly we need a new denture, but here's the thing. We can use this, and the digital workflow can actually help us a lot with this. This is what we meant when we mentioned a reference denture, okay? You have this denture. I went right ahead. You can go ahead and scan this existing denture or the reference denture. And what your lab will do is that they will 3D print a duplicate for you. That 3D print will come to you, and now that will act as your custom tray and your base plate with rims. The rims are not made out of wax, they're the existing teeth, or, well, the duplicate of the existing teeth. But they can act as the rims, right? So you can have your border molded final impression, you can have your intermaxillary records, you can take your CR record, and then you digitize that. Either you scan it or you send it to the lab scans it, and then from there, you'll have the virtual setup, you'll have the virtual try-in, and you're going to have your denture. And that's exactly what I did. I scanned it all around, and this is what Mike sent me. Shout out to Mike. And I went ahead, I actually marked the borders, reduced the borders, tried it in the mouth, had a border molded final impression, and there it is. And this is the intaglio. You can see, what is that blue line? That's my R line, along with my compressible mucosa for my post stamp. I have recorded that, and I have transferred it on to my impression, okay? And this is with the border molded impression and the duplicate inside the patient's mouth. Actually, a patient could perfectly function with it. I checked the aesthetics, I checked the phonetics, okay? And it has very, very good retention because it's border molded, so it has the same retention as my denture is going to have. And obviously you can see that the midline is off. This is something that I communicate with Kevin, and I need to shorten the canines a little bit and all of that, but that's what the virtual try-in is for. Kevin's going to go ahead and do all of that on the monitor. We're going to do it together. We're going to check the cams. We're going to check the incisal plane. We're going to do all those things, and then after the virtual try-in, we can have our denture produced this way. So this will definitely save time, save appointments, and increase predictability. All right. I thank you so very, very much for your kind attention. I believe we didn't do too bad on time. Thank you for being with us.